This podcast is for general informational, educational purposes only and is not to be considered medical advice for any particular patient. Clinicians must rely on their own informed clinical judgments when making recommendations for their patients. Welcome, everybody, to another episode of PHM from Pittsburgh. I am still your host, Dr. Tony Tarchichi. I'm a med-teach-trained pediatric hospitalist here at UPMC Children's Hospital, Pittsburgh. We have been coming to you since October of 2016. Believe it or not, we're coming up on our 6-year, anniversary, we would call it. I don't know what 6 years is, but it's exciting. So, for those of you who are new here, we've been started this Journal Club series. Normally, we do American Board of Pediatric Content Specification topics for pediatric hospital medicine, or a topic that's really hot now. Like a couple of years ago, this COVID thing became very exciting, so we did some episodes on that. But we have decided to veer off because one of the ABP content specifications is research and research techniques and understanding evidence-based medicine. So we've decided to do these 12 or 14 episodes, calling them Journal Club podcast recordings, going over specific areas in research and research techniques and how to understand it. We have been fortunate to have a few wonderful guests to help us with this, and we've partnered with our colleagues in Austin, Texas. Shout out to Dr. Lynn Thorson, who's one of our partners on this initiative. Now, this particular episode, we're going to talk about episode number 3. It's measurement, and we're going to examples of measurement techniques or measurements. We're going to talk about our validity and reliability. With me as our expert guest helping me, because if you've listened to the podcast at all, you know I can't do this alone, is Dr. Philana Lin. Dr. Lin is an associate professor here at the Department of Pediatrics at UPMC Children's Hospital, Pittsburgh, at the University of Pittsburgh. She is also affiliated with the Pediatric Infectious Disease Division. In fact, she's the fellowship director for the Pediatric Infectious Disease Fellowship. She got her BS at Youngstown State University in a combined program. She got her medical doctorate at the Northeastern Ohio Universities. She has a master's of clinical science at the University of Pittsburgh. She did her residency at the University of Chicago Children's Hospital. Dr. Ling did her Pediatric Infectious Disease Fellowship here at UPMC Children's Hospital of Pittsburgh. And her area of focus for her research is, she's a grant-funded researcher, and her focus is host pathogen interaction between HIV, tuberculosis, and immunology. And she now does, even though she did her master's in clinical research, she's been geared towards translational research. So she has a ton of experience, and she's going to help us understand these concepts in statistics and research. So, Dr. Ling, thank you so much for joining us.
Great to be here, Tony.
All right, let's do our disclosures. Ling, I will go first and kick it out to you.
My disclosure is I was on the Sanofi Corporation's meningococcal vaccine in the immunocompromised advisory board, which should have no bearing on what we're going to discuss today.
And my disclosure is I have funding from the National Institutes of Health, the Bill and Melinda Gates Foundation, mainly to do basic science and translational research in tuberculosis and vaccine development in SIV. And I also participate in a pneumococcal surveillance study that is funded through the Baylor Institute via Pfizer. But none of what I'm going to talk about today has any bearing on any of the institutions that fund me.
So, to start, if you've been following along, we have been using a couple of articles that we keep referencing. And this way you can read these articles if you want. We're going to do a quick summary of them, and then we're going to ask the questions we have for today. These are short episodes. So the article we're using is Cerebrospinal Fluid Reference Values for Young Infants Undergoing Lumbar Puncture. It's by Dr. Joanna Thompson, Heidi Sucharu, and pardon me if I mispronounce your name, Andrea T. Cruz et al. This was published in Pediatrics, volume 141, number 3, in March of 2018. Now, I like this article a lot. That's why we're using it. It also brings up a lot of wonderful points. This was a multi-center cross-sectional study. The purpose of the study was to develop age-specific reference standards for cerebrospinal fluid white blood cell counts, as well as cerebrospinal fluid, or CSF, protein and glucose concentrations for infants equal to or less than 60 days of age by doing a secondary analysis of multi-center data to improve the precision and generalizability of reference values we currently have. To do this study, they did a planned secondary analysis of a 23-center retrospective cross-sectional study, which was conducted by the Pediatric Emergency Medicine Collaborative Research Committee, Herpes simplex virus HSV study group. They grouped the infants in less than or equal to 28 days of age and 29 to 60 days of age. For their methods, they use a Wilcoxon rank test to compare CSF parameter distribution, and CSF parameter reference curves were created by using the centiles estimation based on the 4-parameter Box-Cox T distribution to correct for skewness and kurtosis, called the LMST method. Now, a very bare bone basics of what they found, and the article itself, you can read it, it's very good. They found the median CSF white blood cell count was 3 cells per millimeter cubed. The CSF white blood cell counts were higher for infants less than or equal to 28 days of age than for infants 29 to 60 days of age, with a p-value of less than 0.001. The median CSF white blood cell count was 4 cells per millimeter cubed for infants less than or equal to 28 days of age, and 2 cells per millimeters cubed for infants 29 to 60 days of age. The median CSF protein concentration was 57 milligrams per deciliter. CSF protein concentrations were also higher for infants less than or equal to 28 days of age than for infants 29 to 6 days of age. Again, the p-value there was statistically significant at less than 0.001. And the median CSF glucose concentration was 46 milligrams per deciliter. CSF glucose concentrations were lower for infants less than 28 days of age, or equal to 28 days of age, than for infants 29 to 60 days of age. Again, that was statistically significant with a p-value of less than 0.001. Now, the point of all I just read, and we've gone through it, so you have an understanding of the basics of what the article did. We are going to talk about measurement with examples of validity and reliability. And Ling, could you help? Why do we care about this topic? Why are we torturing people by doing this like this? What is important about the measurement and specifically validity and reliability?
So let's just take a step back and ask the question, what is validity? What is reliability? And how do we distinguish the two? And so if you think about validity, we're asking the basic question, how accurate is that measure? So if I were to say, let's say I'm looking at a dartboard, that center bullseye is basically telling me that if I have a test that tells me, yes, I have meningitis, for example, or no, I do not have meningitis, how valid is that? So a valid test would say that I can be very accurate in saying that this test is going to tell me if someone has meningitis or doesn't have meningitis. That can be different than something that's reliable. Reliability basically says how consistent is that measurement. So let's say I am going to measure, let's say, a level of protein. I'm making this up. And I measure it, the same sample, I measure it 10 times. And every time I measure it, it gives me a whole range of different numbers. Let's say it gives me a range from 0 to 10. I might say that test is not very consistent, right? So one can be consistent, but not necessarily be accurate. Let's say we're doing lumbar punctures and I send my sample to the lab and I know that my gold standard, that lumbar puncture is going to be 5 cells, but I send it to the lab and the lab says it's anywhere between 10 to 20 cells. That means it's probably not very accurate. It might be reliable in the sense that I get a range of 10 to 20, but it's not exactly accurate, right? So in a bullseye, accuracy would be, in a target, accuracy would be hitting that bullseye. Reliability, if a test is both reliable and accurate, it's going to hit the bullseye every time. If the test is reliable but not accurate, it may hit 3 rings in that right upper corner above the bullseye, for example. So one can be consistent but not be accurate. But the best test is both accurate and reliable, if that makes any sense. So
Yeah. So if I'm understanding this correctly, let's say there was a ruler, I was measuring how tall I was, and the ruler consistently put me at 6 feet 7 inches.
How tall are you, really?
And I'm not 6 feet 7 inches. I'm 6'2". But that ruler is very reliable. Every time I measured myself on it, it says I'm 6'7", but it's absolutely not accurate. It's not valid because I am not 6'7", I'm 6'2".
Exactly. That's exactly right. So I think that there are many different measurements that can be used where you're testing validity and reliability. Most of these tests that we want to use in the medical field, right, are both reliable and accurate, right? Both reliable and valid. So when, for example, you're making a new test, those things always have to be tested in the field, right? If I do a test out in the field at someone's house, like a home COVID test versus a COVID test that's in the office or in a lab, you're testing both the reliability and the accuracy at all points. I think when you talk about this paper, when we use the evidence based on this paper, right, it is about what's a normal parameter for infants being evaluated for meningitis, right? This is the setting up of normal. And this isn't the first paper. And the paper tells you off the bat, it's not the first paper to examine what normal CSF values are based on age. But the contribution of this paper is actually the number. So it has something like 7,000 patients in it. And it has, and it's done recently. Many of those papers that were done in the past were done when we were still seeing pneumococcal meningitis, when we were still seeing, actually, pneumococcal meningitis is probably the most common, but, many of them were done in an era where they were just coming off of the hip. Right. Yeah. So it becomes more and more important because it's more relevant. It's not only a larger sample size population, but it's more relevant because in this day and age, most populations are fully vaccinated. And so that number may vary by age, and that number may vary based on the population and what the vaccination rate is, because the incidence of meningitis will be lower in this population. So just a couple things on measurement. The measurement might be one of the most important things that one does when doing research, because it is the way in which data are obtained. It is the types of variables that you look at. It is the ultimate primary endpoint that you're looking at. So some people will talk about quantitative, so a value, versus qualitative, which is an overall quality. So for example, qualitative measurements are something like male and female. So they talk about in this paper, they did look at gender, which is what we would call a nominal scale measurement. So in other words, the number might not mean anything. They might assign a 0 to one gender, a 1 to another gender, just to analyze the data, but the numbers don't actually mean anything. Sometimes they will do an ordinal scale. So in other words, you'll get a rank, or there's an interval scale. So sometimes the rank, let's say on a scale of pain might be an interesting one that is sometimes qualified as an ordinal scale. 0 being no pain, 10 being the most pain you've ever had, right? Which is what we typically tell people. 10 means something. 0 means something, right? They have meaningful value and they have a rank to them, but we don't necessarily care about the numbers per se. It's not saying that the scale of 10 pain, a scale of having 10 out of 10 pain is 10 times more than having 1 out of 10 pain. The integers in between them don't really mean anything, as opposed to interval scale, where the numbers matter. So it matters if the CSF count is 5 versus 20. Right? So that is a quantitative interval scaled measurement. It may not matter if they're male or female, but you're going to look at that. It may not matter if, let's see, other measurements that people have used, if they have been in the hospital or not been in the hospital. That's not a quantitative measurement per se versus a qualitative measurement. And in this study, they would not have used patients that had been in the hospital before or who were in the hospital for more than 3 days. So sometimes measurement, you have to actually ask the question, what type of measurement you're using? And that becomes important for the people doing statistics, right? So if you're measuring a mean or a median, so what's the middle number or what's the most common outcome numerically, those things become important. But that becomes more important for statistics. So if you're designing a study, you want to at least look at what types of measurements you're using. If you're ultimately looking at the big question for this study is, what's normal CSF value, right? That's an easy one. Let's say you have a different study. Let's say your measurement is, I am making a treatment for the common cold. I'm making a medication for the common cold, and I'm going to look at what types of measurements are going to be important. So one has to think about what type of measurement actually is going to be important that might be important for the medical field. Not having a cold, reducing the cold symptoms for 2 days, reducing the cold symptoms for 5 days. Or getting people so that they, reducing the symptoms of a cold so that they can actually go to work, for example. So that's a measurement scale, right? Any of those things are a measurement. It's up to you to choose which measurement is accurate, is reliable, and is interpretable. What has meaningful value? It might be more meaningful to me if I'm reducing my symptoms from an average of 5 days let's say with a placebo, to 1 day with this drug that I'm making, for example, right? Is that a meaningful measurement for me? Or is it more meaningful that I can go to work and not have to miss any days, or I can go to work and not miss any days of work? Is it more meaningful that I prevent the infection or prevent it being given to my children so I don't carry it with me to give to the rest of my family? Those are all. You have to choose what is the most meaningful measurement when you're making a study and look at the variables and how you're going to measure it.
I want to try to summarize what you said because I want to make sure I understand it. We talked about validity and reliability already. You talked about nominal and ordinal in terms of the numbers, in terms of measurements. So nominal is a number. So height, 6'7" or 6'2", those are nominal numbers, right?
So on a nominal scale for measurement, it would mean that those numbers don't mean anything. So if we're talking about height is actually what we call an interval scale. So in other words, each number matters. And when we measure height, let's say we measure in centimeters for our centimeters or inches. So 1 inch, or let's say 2 inches, we know is 1 + 1. So that's where the numbers actually matter. On a nominal scale, it would be as if, let's say I'm looking at red versus green teams, for example. It doesn't actually matter. I'm randomly assigning red a 1. I'm randomly assigning green a 2. Those numbers don't matter.
That's nominal.
That's nominal.
So then an ordinal is a scale that we assign value to?
Right.
So the pain scale?
Right.
0 is no pain, 10 is a lot of pain.
Right.
Tremendous. Right. So interval numbers are like height, where they mean something.
Right.
Nominal numbers are things like gender or whatever. Did you eat pizza last night or not?
Exactly.
We assign a specific 0 for no pizza, 1 for pizza. We give, and then ordinal is a scale we create that we give a value to those numbers, and we tell people what those values are.
Right. And we care about the rank. We don't necessarily care about the number. We know that 10 is more pain than 0 or 1.
Okay.
And those things make a difference when you're, it depends on what you're measuring. If you're measuring the effect of a painkiller, or if you're measuring the effect of, let's say you're measuring satisfaction based on whether or not you got a parking permit or not when you were going somewhere. The number matters in terms of rank, but the quantity of the number doesn't necessarily matter.
And these are all quantitative values that we're using. Qualitative studies are more richer studies where people give a lot of information, or any of these values you'd consider qualitative, not quantitative?
So interval scale for measurement is definitely quantitative. I think that ordinal scales and nominal scales, it kind of depends on what you're asking. Nominal scales is certainly quality, right? So if I say yes or no, gold or silver, red or green, boy or girl, those things are much more qualitative. In terms of quantity, ordinal scales, I think, can be debated, especially in psychology and when you're measuring things like quality of life, for example, or things that are much less quantitative. Those are hard, right? So the social sciences do those a lot and have formulated statistical measurements on how they can compare them. We like numbers in science, but we recognize that sometimes the numbers don't give you the true value of the meaning. And so you have to be a little bit, you have to be able to talk in both qualitative and quantitative reasoning.
So, and if I'm understanding validity and reliability correctly, the lumbar puncture cell count that each of the other centers in this study got and sent in to be evaluated, we have to assume the accuracy or the validity of those numbers. Meaning if the number says 3 cells per millimeters cubed, we assume that there are 3 cells per millimeters cubed in that CSF and not more or not less.
That's correct. And in fact, every test, at least at UPMC Children's Hospital, every test that we use has been tested by the lab to ensure that it is both reliable and accurate. Now, the commercial tests that you're using, they will tell you that they are both reliable and accurate. We also like to do them in our lab to make sure that they are, at least in our hands, both reliable and accurate. And you'll notice, the COVID test, the rapid tests that you do at home have been tested at home, but they have also been tested in primary care offices to make sure that everyone's getting the same result from the same sample. So every institution across the country that does any type of major testing will always look at the accuracy and the reliability of the assay, not just the assay itself, but also how it works in the field, how it's working within their lab, because they want to ensure that every specimen that gets in there is going to be both reliable and accurate.
All right. That's so helpful. So just to recap, validity is how accurate is a measure.
Yep.
If we're going back to my height example, if I'm 6'2" and it says I'm 6'7", the ruler's not accurate. It's not a valid
Or
test.
something happened, Tony. I don't know why you'd be growing 5 inches. My children still hope they're going to grow.
Yeah, it doesn't end.
Oh, or maybe you're sitting on a 5-inch step.
Yeah. But reliability is consistency. So if that ruler continually tells me I'm 6'7", it's super reliable, it's just not accurate, not valid.
Right.
Interval scale numbers, since we're on height, are things like height, where there's a consecutive nature to it. Ordinal is something we assign a scale to. The pain scale is the most common. Or did you like this lecture? 0 for no, 10 for loved it more than anything else. And nominal are just things that are more qualitative, but we assign them numbers. So brown hair or blonde hair is 0, brown hair is 1. We assign those numbers to be able to do statistical analysis on them.
And the numbers don't mean anything.
They don't mean anything. We come up with them on our own. Wonderful.
Right.
All right. Do you think we covered it well enough, Ling, for people to have an understanding of this?
I think so. And then I think it will be up to our librarians and statisticians to help us out when it comes to how we actually look at these numbers, should we want to analyze them. I mean, I would hope that like any major peer-reviewed paper would be able to explain or at least be transparent about the type of analysis that they do statistically and what their thought process was of doing it. I always find it helpful to have someone who knows something about statistics to help when you're reviewing a paper, to give you some background as to, yes, this makes sense, or no, this doesn't make sense. Because when you go to review a manuscript before it is accepted for publication, we are oftentimes asked, do you feel comfortable with the statistics? Do you think that there's an expert in statistics to help discern whether or not the data is analyzed accurately? So it's, these days there are very large population-based studies. It is always worthwhile to ask someone who has an expert opinion on it to make sure that your interpretation of that paper makes complete sense and that you're utilizing it in a correct way.
That's the beauty of our peer review system. We hopefully do our best to make sure not everything gets published, only things that are worthy of being published that add to our general knowledge in science.
Right. And if there's a limitation, that's the whole sort of point of doing a journal club, for example, is talking about the things that you will learn from it. So the generalizability to your patient population. And then what are some limitations? Not every study is perfect. Some studies were meant for a very specific population, and that's all it addressed. And we tend to extrapolate from them. But we do need to be cautious about the validity of the data and the accuracy and the design of the study to say, yeah, they looked at this, or to say, they didn't exactly look at this. And maybe there's a better design out there. Maybe there's another study addressing the specific population we're concerned about. Maybe there's not. And maybe we just use expert opinion and logic.
I don't think there's a better way to end this episode. This was great. This was episode 3, part 1 on our Journal Club series. The next one in line should be types of variables. We kind of touched them a little bit. Continuous, ordinal, and nominal. distribution of data, example mean, standard deviation, and skewness. Tune in for that to continue this conversation. Thank you for joining us. We genuinely hope you got something out of it. Ling, I really thank you for coming on and helping us with this. It's immensely helpful. Thank you.
No problem. Sure thing.
Thank you for joining us for this Journal Club series at PHM from Pittsburgh. We want to especially thank our expert guests for their time.
Special thanks to the University of Pittsburgh for sponsoring the CME for this podcast, and UPMC Children's Hospital of Pittsburgh for supporting this podcast as well. We want to thank our friends at Dell Children's Medical Center and the University of Texas at Austin for their partnership on this endeavor.
Please email my dad at tony.tarchichi@chp.edu with any questions or comments. And as always, thank you for listening!